take on over and roll.
Alrighty, can everybody hear me okay?
Yes, we can.
Perfect. So again, I'm Kelsey Coe. I am one of the PGY4s. Today, I'm actually going to be talking a little bit about several different kinds of patterns of abuse that I think that we should be aware of in orthopedic clinical environments. I did just want to give a trigger warning at this point to the audience that we will be discussing some sensitive issues, including domestic violence. I have no financial disclosures. And then I also just wanted to take one moment in honor of the beginning of Black History Month this week to recognize the accomplishments of Dr. Claudia Lynn Thomas, who is the first Black female orthopedic surgeon in the United States. She's really been a revolutionary throughout her career. As an undergrad, she fought alongside her classmates at Vassar College in 1969 to establish a Black Studies major, during which she found herself barricaded in a university building against threats of violence and retribution from both staff and peers. And she's gone on to graduate from Yale for residency and has from residency and has fought to protect minority patients from bias in medicine throughout her career and has been recognized by the Academy for her efforts to improve diversity, equity, and inclusion in our profession. So I just wanted to take a moment to recognize her today. As an outline for my talk, first we're going to talk a little bit about a case example. This talk was inspired by a situation that I found myself in the emergency department as a junior resident. I'm going to talk a little bit about different patterns of abuse. We're going to talk actually mostly today about human trafficking and intimate partner violence rather than child abuse today. And then I want to talk about how we can apply what we've learned to orthopedic clinical settings. I know evaluating patients in the emergency department and the access to resources there is different than what we have available to us in orthopedic clinics commonly. And then just provide some kind of local resources for patients that I think we should all be aware of. So I'd like to start with the case. So we're called to the emergency department in consultation to evaluate the right index finger of an otherwise healthy 19-year-old Spanish-speaking male. He's had about 1 week onset of finger pain after he sustained a laceration to the dorsum of his right index finger while he was working in a field. And over a week or so, it became progressively more swollen and painful and red. And he's noted by the emergency department to have a dorsal abscess on his finger. So while we're taking the history, we're using an interpreter, and we noticed some other things. He notably avoids eye contact during the history. Instead, there is a man who is accompanying him who claims to be his boss, who's really answering many of the questions for him. When we ask him his phone number and his address as we're trying to, help arrange hand follow-up, we notice that he does not know his phone number or where in Charlotte he lives. And so we sort of think to ourselves, well, when's the last time you've met a 19-year-old who didn't know his phone number? So because of this, we raised concern to the emergency department team that this story may be concerning for labor trafficking. And so the on-call social work team is consulted. So we'll come back to this story in a little bit, but wanted to start here. So as I mentioned, this talk was inspired by a situation similar to our case, which ultimately turned out to be a situation of human trafficking. But I think that there are several patterns of physical abuse that the orthopedic surgeon should be familiar with. I think many of us have had training on identifying non-accidental trauma or child abuse. And I think our emergency department colleagues would consider us experts in some situations of identifying certain fracture patterns, for example, that may be higher risk to be non-accidental trauma. But I would challenge us to consider domestic violence or intimate partner violence, human trafficking, or even athlete abuse in our clinics, because I know that in particular has become a topic of media attention in the last few years. So I think all of these really should be on our radar. And I would, again, challenge everyone in the audience to consider your individual practice and who among your patients may be vulnerable to these situations, and to be on the lookout for them. So really my goal today is to give you some tools to do that efficiently and effectively in your practice. So you may wonder if human trafficking, for example, is very common in our area, and I would tell you that it is. In 2017, North Carolina actually was home to more hotline calls to address human trafficking than any but 7 other states in the US. And there's some reasons why we are uniquely positioned for this. You know, we sometimes, I think, maybe in movies and things, think about human trafficking related to sex work, but there are many common labor trafficking industries in sort of legal industries such as agriculture, construction, food services, et cetera. Charlotte itself is really an ideal environment for labor trafficking because it's a large expanding city with neighboring rural areas. It's a transportation hub that draws large crowds for major sporting events and other events, and has a thriving nearby agricultural community. Specific populations at risk you might expect: migrant laborers, populations with limited English proficiency, youth who experience homelessness, people with disabilities, or LGBTQ folks. All right, so what specific red flags in a history and physical exam should raise our concern about abuse or trafficking? I think some of these we know: signs of poor mental health. Maybe the person is fearful and anxious in the exam room. They may be submissive to another person who is there with them, or acting paranoid, avoiding eye contact like our patient did. They may lack access to healthcare and so be in poor physical health or malnourished. In their personal life, they may have lack of control, whether that means that they have few possessions. They may not be allowed to be in control of their own money or their identification, and they may be discouraged from speaking for themselves. Other things which we noted: they may claim to be just visiting the area and explain that as sort of, or use that as an explanation for why they're unable to provide their address or know where they are. They may have a lost sense of time or just inconsistent history. I think we all recognize that as a something that should raise our concern when we're talking to patients about their particularly mechanism of injury. So thankfully, our partners in the emergency department at Atrium are really leading the way in identifying victims of abuse and developing systematic approaches to caring for them. Much work has really been done to streamline the care of these patients, whether they're victims of non-accidental trauma, intimate partner violence, or human trafficking. So this is an algorithm that was taken directly from the ER, from ER protocols. And it really drives the care of patients who've been suspected of being trafficked. So to break it down, essentially, there's sort of 4 components. First, it recommends we identify those red flags that we discussed. Second, really address their critical medical needs first, address their orthopedic issues, make sure that they are stabilized from an overall health perspective. And then take the opportunity to one-on-one screen them in a private environment, discuss with them your concerns, screen them for additional risk factors. And then if you have suspicion, but they maybe aren't disclosing, if you're in the emergency department environment, or I believe if you see patients on CMC's campus, like at MMP, you can consult social work directly to clinic or the emergency department. There's a specific human trafficking team that's been specially trained in how to discuss this with patients. I would just mention here that adult abuse and child abuse is a little bit different in the state of North Carolina. We are not mandated reporters of adults, which means in children, certainly if you expect abuse or trafficking, getting DSS and law enforcement involved is required of us. However, in adults, it's actually a HIPAA violation if they do not consent to you involving law enforcement. So just note that adult patients may or may not be ready to take that step. So again, we discussed that this is a problem. We know that the ER has more maybe resources to address some of these social issues than we do in our orthopedic clinics. So what do we do if we're not in the ER? Certainly, I can think of some barriers to addressing this in clinic. And I would start by just saying most of the orthopedic literature regarding physical abuse in adults is directed at intimate partner violence, but I think we can apply some of these themes broadly to safety for all of our patients. So I thought this study was interesting. In 2013, a group of 20 orthopedic surgeons and residents came together to, in a focus group, to discuss the perceived barriers to screening for abuse, particularly in orthopedic fracture clinics. And they identified four major areas of concern. They felt like fracture clinic in itself had some barriers, whether that was kind of a fast-paced clinical environment, maybe less privacy, less opportunity to, obtain an entire full patient history. They identified concerns about barriers on the patient side. Maybe the patient notices an opposite gender of the surgeon, or a power imbalance with the surgeon they may feel less comfortable disclosing, maybe compared to other physicians. Orthopedic residents identified their own concerns about this. They, noted that in clinic they're really worried about learning orthopedics, and they have multiple demands on their time as well. They also noted that the resident preceptor or resident attending relationship might affect how this conversation goes. And then attendings noted that they felt like just the culture of orthopedics may be a barrier to discussing this issue in clinic. And they also noted a concern that they didn't really have somebody in clinic who could really follow through, or what they called a champion, to make sure these patients were getting access to resources. A similar study in 2011 demonstrated similar concerns by orthopedic residents. I think the most probably notable thing about this study was just they titled it, the quote from one of the participants, "I've never asked one question in clinic about intimate partner violence." And I argue that I think we can do better than that. So is our knowledge of this subject a barrier? Dr. Della Rocca in 2013 surveyed all OTA surgeons, and 153 responded to a survey about knowledge of intimate partner violence. And I think that there's a couple of interesting findings from this study. First, 74% of OTA surgeons surveyed thought that screening for intimate partner violence was relevant to their practice. 51% said they had identified a patient experiencing intimate partner violence in the last year, but only 4% actively screened for it. And unfortunately, only about half of surgeons surveyed wanted any additional training or information on this subject, but for the 49% of you that did want additional info, I'm here for you today. So what about time as a barrier? Certainly time to address sensitive issues in clinic can be a barrier. And to help find the most efficient way possible to screen for this, Sprague et al. Compared basically two validated screening tools for intimate partner violence, which are longer surveys. They compared those two head to head with simply these three questions in an orthopedic clinic. And what they found was that asking only these three questions was as or more sensitive than the two validated screening tools for them. And they had about a 30% positive rate when asking women these questions in an orthopedic fracture clinic. So I would pause here and just ask you to please take note of these three questions. I'd challenge you to maybe consider adding them to your review of system paperwork, or maybe go to them if you start to recognize some of these red flags that we discussed earlier, because I think these are three pretty quick questions to ask that really can make a difference for not only the care of your patient and their orthopedic problem, but even potentially save their life. So finally, how prevalent is intimate partner violence? This Lancet study evaluated over 2,000 women across 4 countries in orthopedic clinics, and participants completed the 2 previously mentioned longer questionnaires that I mentioned. And the findings are quite staggering. 1 in 6 women, again, in the orthopedic clinic endorsed experienced intimate partner violence in the last year. 1 in 3 had experienced intimate partner violence in their lifetime. And notably, 1 in 50 in the orthopedic fracture clinic came as a direct consequence of intimate partner violence. Of the 49 women in clinic that were there as a direct consequence of this violence, only 7 had ever had anyone ask about intimate partner violence in a healthcare setting. So to put this in context, I actually looked at the orthopedic trauma service as a whole last week. And as a service, they saw 132 patients in clinic. And so for the sake of argument, let's just assume half of them are women. Maybe in the trauma population, that's slightly less, but that would be 66 women that they saw last week. So it's possible based on these statistics that at least one of them was there as a direct result of intimate partner violence. So again, I think we're seeing these things maybe more often than we realize. What about privacy as a barrier to talking to patients about this? Our colleagues certainly identified that as a concern, but here are a few strategies for interviewing the patient alone. You can separate the patient from someone they're with by requesting they move to another area for another X-ray, for example, or other diagnostic test, kind of remove them from the clinic room if that's the best way to do it. You can also engage the other party by asking them to step out of the exam room to maybe help with paperwork or scheduling another visit. I'd also just take this time to remind everyone when you're talking about these issues with the patient to really think about it and interview them in what I would call trauma-informed way, meaning to try to minimize the number of people asking them the same questions about these topics. If you know you're going to have social work involved, ask the minimum amount that you really need in order to know kind of what your next step is in order to prevent them from having to repeat themselves and repeat this trauma frequently. And then just recognize that they may decline assistance initially, and really that they are the best judge of their safety and readiness to leave a situation. I think famously, many of us have heard that perhaps the most dangerous time for a person experiencing violence is when they decide to leave that situation. So moving forward here, if we put all of that together, here's my suggested algorithm for orthopedic clinic. I think first of all is just identify the red flags, note if those sort of concerns are raising your spidey senses and listen to that. Secondly, address their orthopedic issues, certainly. 3, do your best to screen them in private. If they're above 18 and you have concern, even if they don't disclose, don't hesitate to give them access to resources in a discreet way. We'll talk about that in just a second, whether it's a crisis hotline phone number, a trafficking hotline phone number. And then again, know that if they're under 18, that you are mandated to report your concerns. So if we go back to the case, what ultimately happened, so as I mentioned, we consulted social work in the emergency department who came in the middle of the night to interview the patient. He initially denied that he was being trafficked, but notably made an effort to memorize the phone number for the human trafficking hotline, which social work noted. He ultimately was discharged, went back to the farm and met up with his family. And days later, they actually did call the hotline. Law enforcement went out to the farm and extracted his entire extended family. And we learned that the men were being labor trafficked and the women were being sexually abused. So here again is just another resource slide for you. The top is the National Domestic Violence Hotline. They have web and text-based and as well as phone call-based services. So does the Human Trafficking Hotline, which is listed below. There are a number of resources in our community. I'm just going to put this slide up here for now. Polaris Project is a great one regarding human trafficking. And then finally, you may have noticed throughout my presentation this what appears to be a barcode. If you pull up your phone, you'll realize that it's not actually a barcode, but it's a discrete way to try and get the human trafficking hotline phone number available to patients. So there's discrete ways that we can get this information to them. That I think is just important to realize that any documents, any paperwork may be rifled through by their potential abusers. So here are some resources, and thank you very much.
That's fantastic, Kelsey. It's a kind of a pretty moving case story, and I think it illustrates one of the things we don't think about, which is them having other family members and or friends back in that situation. And it's pretty cool that he was able to remember that number and get everybody out of that situation. So I think really nice talk. And sorry for underselling your talk. I see a person going into peds and I see abuse and immediately went to NAT. So thanks for that really, really nice talk.
But I think that serves a good point that really each of us, I think, is seeing injuries of some kind likely or is interacting with patients. And I think the data suggests that most patients who are in these environments end up interacting with healthcare professionals while they are in these situations of abuse. So I really think that we have an opportunity to intervene if we kind of keep our ears open and eyes open to the red flags.
I would like to commend Dr. Coe on her work in this area. I have to tell you, she asked me a couple of questions early on about this type of work and screening for this. And it took me about 15 seconds into that conversation to realize that she knew way, way more than I did about this. And I basically started taking notes on it. And she has undergone educating me over the years. So thank you for continuing to do that, Dr. Coe.
Well, and I'd just like to thank Dr. Shu. I think the work that he's done to institute depression screening in his clinic really sets an example that we really can do this if we're willing to ask the right questions, and it doesn't take a lot of time and really does impact patients, not just in their orthopedic needs, but really in their life.
Hey, Kelsey, this is Jess Salzman. Can I add something real quick?
Oh, yes, please. Dr. Salzman is one of our pediatric emergency department colleagues. For everyone on the call, she was instrumental in helping me put this talk together and has really helped me with access to the right people and resources. So please, Dr. Salzman.
Thanks, Kelsey. I really enjoyed your talks, and thank you so much for doing this. It's such an important topic. And, you know, I want to
I think maybe we lost you for a second, Dr. Salzman.
One thing I wanted to add too, you mentioned about mandatory reporting, and I just wanted to clarify, adults do, qualify for mandatory reporting if under certain circumstances. So, not in most cases, but
Oh, I'm sorry, Dr. Salzman. I hope it's not just on my end.
Instances, then that does fall under mandatory reporting.
Dr. Salzman, do you mind just repeating those instances one more time for us? I think at least on my end, you cut out right when you were telling us that.
Oh, sure. So if a weapon is involved, either a knife or a gun in particular, and also if it involves grave bodily injury. So of course, the grave bodily injury is a bit of a gray area, but those are the two instances that you would be required under North Carolina to report. And, in those instances, you just want to be upfront with the patient and say, look, I am a mandatory reporter. I am required to call the police in these cases, but we want to work with you.
Sure. Thank you so much for adding that.
Sure. Thank you.
Hey, Dr. Coe, I have a quick question. That was a great talk. Thank you so much for giving it. This is Joseph. I think we've all been in situations where, especially in a patient that doesn't speak our same language and we're using an interpreter, I feel like it's pretty frequent that another person in the room, whether they claim to be a family member or whoever, tends to try to speak for the patient if they speak more English. And how would you go about kind of navigating that situation where it seems like someone in the room, whether malicious or not, keeps trying to speak for the patient?
Yeah, I think that's a common problem, whether it's that situation or even, sometimes in our adolescent patients, for example, they have a lot to say and sometimes parents or others want to kind of step in. So I agree that I think we've all been in that situation. I think really the best practices with either using an interpreter or really just taking the history are trying to redirect back to the patient, give the patient that opportunity to speak through the interpreter, but then also let the other person in the room know that you'd like to hear from them as well. And their perspective, they've obviously arrived with the patient that day. So I think maybe just trying to separate it of recognizing that you'd like to speak to the patient and then give separate time to the other person involved is probably the easiest and least abrasive way to address that, but certainly can be a problem. And I think, if that's your only red flag, then that's something you consider. But I think maybe in combination with other things, that's how you know kind of how suspicious you should be.
Excellent. Well, thank you again, Dr. Coe.